Welcome to the NANB webinar titled Problematic Substance Use in Nursing, Still an Important Issue. Due to the sensitivity of the content in this presentation, this webinar was recorded in front of a limited audience. This is not the usual presentation of NANB webinars, and so we thank you for your cooperation. This is going to be a presentation that will enrich you as a person and as a professional. Thank you for watching this webinar with us. To commence the NANB journey regarding problematic substance use, we have to go back about 20 years to 1994 when NANB participated in an educational endeavor that was spearheaded by both CNA and the University of Toronto. The purpose of that project was to educate nurses and to increase awareness regarding problematic substance use in nursing. The final outcome of that project resulted in a very good educational tool titled Web of Denial. At the end of that project, NANB published the document, The Recognition and Management of Substance Abuse in the Nursing Profession. When I arrived here at NANB in 2008, both the Web of Denial and the 2003 publication by NANB were being used as resources to our members and for the student nurses in New Brunswick. And then 2009 arrived. In 2009, NANB saw a spike. If you look on the slide, you can see the 2009 year with the number 17. We saw a spike in formal complaints against registered nurses. The total number of new complaints received were not all related to problematic substance use. However, 7 out of the 17 were. And on top of that, between the years 2004 and 2008, 43% of the cases that were referred to the Discipline and/or Review Committee were related to problematic substance use. So with over 40% of the official complaints against RNs over a 5-year period being related to problematic substance use, and then with a spike in the number in 2009, NANB felt strongly to address this issue in a more overt manner. So right now I want to stop and pause and look at the complaints from 2009 of those 7 that were related to problematic substance use. And I'm doing this because in case you have preconceived thoughts about how old these nurses were or their clinical experience, this slide might be a contradictory of what you thought. Looking at the screen, you can see that all of the RNs were female, which isn't surprising, seeing that we are still predominantly a female profession. However, you will note that their ages and their years of practice ranged greatly and that they were not new to the profession. I found that a bit surprising. I had a bit of a stigma, which I think is probably not uncommon, that they were probably a younger generation or younger persons. So in 2009, the journey continued, and I was assigned the portfolio of revising the 2003 publication on substance abuse in nursing. At that same time in my scholastic life, I was finishing up my Master's of Nursing and doing research on problematic substance use in nursing. Well, after speaking with UNB instructors and professors and speaking with my director at NANB, I changed my course of studies and focused on problematic substance use in nursing. I did a gap analysis of the 2003 NANB document with the existing literature. So from that graduate work, NANB revised the 2003 document, and we prepared for an invitational forum. And so in 2010, NANB invited educators, employers, nursing leaders, and nurses from the Department of Health to a half-a-day forum on problematic substance use. This was a first for us. The New Brunswick Nurses Union was also present, and they were very supportive in this endeavor because they too were very concerned with the growing numbers of registered nurses living with problematic substance use. Also present that day was our liability provider, the Canadian Nurse Protective Society, and they gave a presentation regarding the legal aspects to consider when the RN is practicing under the influence of a drug. We took the information from the forum and the revised NANB document, and the practice department went on what we call the road show across the province to speak with RNs in various settings, so meaning the acute care, the long-term care, and the educational institutions. And we engaged registered nurses, nurse practitioners, and nursing students. We visited each of the 7 university campuses, and we delivered our message about problematic substance use in the profession of nursing. NANB, as I stated, went on to publish the revised document, and we changed the title to Problematic Substance Use in the Nursing Profession. And we also went on to develop more recently an e-learning module that is available to members and to nursing students through the NANB website. So I want to stop right here for a moment. You'll see the title page of our NANB document, and you will also see a section of our e-learning module. The reason why I want to stop and pause here is because the research shows that the more we learn about problematic substance use, the more we talk about it and the subject matter and the signs and symptoms and how to intervene and what to do, then the research shows the more this is discussed, the more successful nurses are at recognizing problematic substance use, in intervening effectively, and in the end, we're helping both the healthcare provider and the patient receiving care from this registered nurse or physician or whatever title they may have. So if you ever suspect a colleague is living with problematic substance use, this document and this e-learning module are very good resources. NANB, we chose the word problematic substance use or the term problematic substance use because it is meant to encompass all facets of substance use. It is also the terminology used by the Canadian Nurses Association. And it's important to point out that problematic substance use affects job performance and renders the nurse unable to meet the standards of nursing practice, which include providing safe, competent, and ethical care to clients or patients. Quite often in the literature and also in practice calls, there is a great debate, or the question comes up in the literature about whether problematic substance use is an illness or a symptom of an illness. It is like the chicken or the egg phenomena. A psychiatric illness can lead to problematic substance use because prescribed medications may place the client at risk for chemical dependency. However, longitudinal studies have found that drug abuse may predispose the drug abuser to a psychiatric disorder because of changes in the brain chemicals, because of social isolation, and or the stigma that's associated with being a drug user. So what do our registered nurses and nurse practitioners need to know about problematic substance use? After reviewing the literature and after surveying members, NANB concluded that our members should know statistics, what the literature says about problematic substance use, risk factors, and how to recognize it. We also need to talk about the responsibility and the accountability, and then of course resources, what's available to help us. Nurse colleagues, it's very important to point out, are mandated to intervene when they suspect another nurse or nurse practitioner of problematic substance use, because it would fit under fit to practice or not fit to practice. The literature repeatedly stresses the importance of education to healthcare professionals regarding problematic substance use, and we've talked about that earlier, how it shows that students and staff who were educated on this subject matter were more likely to intervene. They were less likely to just divert it or shove it under the carpet. So the underlying message today should continuously be that patients need to be safe, and colleagues who are living with problematic substance use need help. So this is what brings us today, and this is an exciting day for me. I have with me today a registered nurse who is going to share her professional and her personal journey of being a registered nurse who lived with problematic substance use. I have not told Helen what I want her to say, nor has NANB suggested what we think she should share or not share. This section of the webinar is raw, it's honest, and in my opinion, it's the type of educational experience that will show how problematic substance use is very real here in New Brunswick and in the profession of nursing, and how that it is very serious. So welcome, Helen, and thank you for joining me today. We have met and talked several times leading up to today. I would like for you to share with us why you choose not to be anonymous with this presentation.
Well, first of all, Suzanne, I want to say thank you very much for inviting me today to share my experience, strength, and hope. I would like to start off by answering your question why I have chosen to not remain anonymous, and primarily that is because in remaining anonymous, I am perpetuating the shame that comes with this illness. I have and will continue to respect others' anonymity, but I've made a personal choice to speak openly about this. I have a great amount of remorse for practicing under the influence of substances, but that's quite different from feeling guilty and ashamed for suffering from the illness of addiction. And in terms of my remorse associated with my behavior, practicing under the influence and being actively in my addiction, I've tried to atone for that behavior in my recovery and the work that I am currently doing with addicts, and by my return to work with a strong recovery, to work as a competent, safe-to-practice nurse. And I talk openly with my colleagues about this important issue. My hope is that in sharing my experience today, that other nurses caught up in this nightmare will see that there is hope and that there is a way out. You don't have to live like this. You don't have to quit practicing nursing if you are willing to do the work that recovery requires.
Helen, would you share with us today the events leading up to that last day on the medical unit where you worked under the influence of a substance? Take your time, gather your thoughts, and share with us.
Okay, my story. I guess I would go back to my history of coping with stress and uncomfortable feelings was looking for some sort of release through alcohol. I was quite a heavy marijuana user, and I did this all throughout my life and continued through nursing school to deal with the stress that I felt by using substances to decompress, to unwind, to deal with anxiety. I also suffer from clinical depression. So again, I was in the habit of. I developed the habit of self-medicating, as a lot of people struggling with mental illness do, despite the fact that I was being treated with prescription antidepressants for that illness. When I started practicing nursing in 2005, I can remember feeling that I had this constant feeling of not being good enough, not being as smart as my colleagues, thinking that it was just a matter of time before everybody found out that, you know, I wasn't very smart. I've got a history of being a perfectionist and overachiever, wanting to be the best at everything I do, and that's pretty much impossible in any profession, and certainly was in nursing. So I always lived with low self-esteem, a lack of self-respect, and this constant fear that I would be found out for not being good enough and not knowing all the things that I should know. I remember quite clearly the first time that I actually stole a narcotic on the nursing unit. And it was a day, just to create the situation for you, it was a day that we were working short. I had come to work with a migraine headache coming on. Anybody who's worked in nursing knows that we hate to call in sick because we know what our colleagues go through when we do that. In any case, I had taken a prescribed dose of Tylenol 3, and this was proving to be a migraine that wasn't going to give up. I was giving morphine to a patient. It was a 10 milligram pill, which I was required to cut in half and give the patient 5 milligrams. I had the other 5 milligrams in my hand, and it was to be disposed of, and instead of throwing it out, I thought, wow, if I take this, maybe I'll feel better. So I promptly tossed it back, took a drink of water, and swallowed it. At the time, I was quite shocked at what I had done, but in my mind, I justified it, thinking, number one, it's being thrown out. Number two, I'll be able to stay and finish my shift. What happened when that pill kicked in was not only was my headache gone, but I had that overwhelming sense of comfort and ease. I almost felt like a super nurse. All my anxiety and self-doubt slipped away, and I felt like I could do anything, which is, you know, the one of the side effects of a narcotic, or an opiate rather. So that was the beginning of a horrific journey. I didn't steal any medication after that for a few more days, but again, being on a night shift, being tired, feeling stressed out, I was looking for a little pick-me-up, and it happened again. The behavior escalated as I became physically and mentally addicted to these substances. In order to behave like this, there's something that goes on in an addict's mind, in that we try and justify our behavior because it goes against what we know is right. So we make it right by telling ourselves lies. And I know that I had a sense of entitlement back then. I work in a high-stress profession. Sometimes I felt like the expectations were unrealistic, and I felt like this is helping me to do my job or do it better than I could. All of those are not true, and I realize that now. Addiction is a progressive illness, and mine certainly progressed to the point that I was routinely taking the waste narcotics after I had given the prescribed dosages to patients. Most people listening to this webinar will realize that quite often the narcotics that are prescribed for patients are partial doses of the stock that we have in our cupboards. So if, for example, I was required to give a patient 5 milligrams of morphine, I could easily give them the 5 milligrams of morphine. In an average working day, especially where I worked on palliative care, we don't have time to have nurses physically witness us throwing away the drugs that we don't use. So they will go in and type a signed witness when in fact they haven't seen it being disposed of. And this is just common practice, and I'm not interested in commenting on the reality of that situation, only to say that even if that were not the case, there are other ways of getting around it. Addicts are extremely creative in getting what they need to survive.
Thank you, Helen. So what are signs of addiction that you displayed and others should be aware of?
As my addiction progressed, Suzanne, my behavior was becoming more and more bizarre. Knowing what I know now, and at the time I wasn't aware of this, but I was quite obviously under the influence of something. I was drowsy and falling asleep over my charting. My words were slurring by times. My addiction had progressed to the point where I required this narcotic just to stop myself from going into withdrawal. So we were talking about huge quantities. It became more and more difficult to obtain the amount of narcotic that I needed to stay well, and more difficult to even get any kind of a high from these narcotics, which is what I was seeking as an addict. The signs that I displayed that would have been the most recognizable were, number one, frequent trips to the washroom, probably about every 20 minutes to half hour, and taking my purse in with me, because quite often you're hiding the medication in a bag or a purse because you don't want to be caught with it in your pockets, although that did happen. So frequent trips to the washroom, lot of absenteeism due to quote-unquote illness, dealing with the fact that I was getting sicker and sicker, trying to quit, trying desperately to quit my drug abuse, so doing self-imposed periods of detoxification where I would be in bed at home for 5 to 7 days going through a horrible withdrawal. And so my absences from work were frequent. Other signs, let me think. Picking up, another one, picking up extra shifts. I became very popular because whenever the administrative officer called looking for someone to pick up a shift, I was quite often sitting at home praying that they would call so I could go in and get some more medication to feed my habit. So I was actually working overtime hours and picking up for sick calls frequently. And the other thing that I was doing was coming into work extremely early. A lot of nurses will typically come in, half an hour early for their shift just to prepare, but I'm talking about coming in an hour to an hour and a half early for a shift because I was running out of narcotic or I needed to get it into my system so I could think clearly. Coming in, say at 6 in the morning when I knew the other nurses would be doing their morning rounds so I could get at the machine and get what I needed. The other thing that I did was staying quite late. I was always behind on my paperwork, and also sometimes I had to stay late because I hadn't been able to get the narcotics that I needed to take home with me to get through the evening. So, that's something that all those things are things that are signs of addiction in a nurse that's working on the floor.
And this is just amazing, and I want to stop and commend you for how well you are doing and sharing your story with us. I know this isn't easy for you. Do you think your colleagues picked up on your symptoms of problematic substance use? And if so, do you think they reported you?
I know I work with a very close group of nurses and a very supportive floor, and I know that they were frustrated and exasperated with me. In hindsight, I am now working on the same unit, and they have told me that they did know that something was wrong. They suspected drug abuse, but they didn't know exactly how much it was, what was going on, and they certainly didn't know what to do about it. I only know of one nurse. I only know, in fact, of one nurse that reported my behavior to my nurse manager, and of one doctor who reported that I seemed to be under the influence because I was slurring my words. Now, if there were other these were documented and written out by these two people. If there were other of my colleagues that actually went in and expressed their concerns, I don't know if they did that or not. I do know that they have said to me, which really surprised me, when I returned to work, a lot of them were very apologetic, saying, we knew something was wrong, we just didn't know what to do, and we're so sorry we couldn't help you. And so that was quite overwhelming to me, that they would actually apologize to me for not being able to help me.
And that is really quite remarkable, and it shows why we are doing what we're doing today, because statements like that is evidence that nurses do want to know, what do I do, or who can I call for help, or are there resources for us? On to the next question. What do you think was your point of no return, so to speak? What happened to make you reach the point of ending the cycle of living and working with problematic substance use?
That's a question that I find difficult to answer, but basically, to be honest with you, number one, I was very, very sick. I was so tired and exhausted. I was trying to get enough medication just to stop from getting very, very ill. I had this sense of impending doom. I felt like I was on the brink of getting caught. There were several confrontations or attempts to confront me made by my nurse manager, which I was able to lie my way out of very convincingly, and addicts are very convincing, mostly because they partially believe what they're saying. I had tried so many times, Suzanne, to quit on my own. I had tried tapering off, even according to the documented ways we taper patients off narcotics in the hospital. I was following, I researched it in one of my guides, how to taper people off narcotics in a medical situation. That didn't work. I tried taking a leave of absence for a month. I traveled overseas. I came back. I was back maybe 4 days, and I was back abusing substances again. I realized at some point, and it wasn't an overnight realization, but it became clear to me that I could not stop on my own. At that time, I didn't even think I'd be able to stop with help, but I was just so desperate. Along with all the shame and guilt that I had at that time, I couldn't bear the thought of being caught red-handed. I also, by luck, sheer luck, I had not harmed any patients as a result of my substance abuse. I'm sure I didn't give them the best care that I could have, but there had been no physical harm to patients, and I knew that if that happened, for me personally, there'd be no coming back from that, just for me. So the very last day of work, I had taken a narcotic from the AccuDose machine, and I had just hidden it in a patient's room to get at it later, and it was discovered missing. And there was a discussion between myself and the charge nurse and my nurse manager, during which I pretended to find it, and I can't even remember what I said, but again, I lied my way out of that situation and left work. It was a Friday, and I went home and realized that I couldn't go back to work until I did something about this.
Wow, that's phenomenal. So why do you think nurses do not seek help for problematic substance use? You have shared how you try to fix it on your own countless times. And so I guess the question that hangs in the air at this point is, why do nurses not seek help? There has to be a reason. If you're desperate and you recognize that you have a problem, why do nurses not seek help for problematic substance use?
Well, while I was trying to quit abusing substances, I was also actively looking on the computer to see if there was any help for nurses who were addicted to substances. And so I Googled it. I tried and tried and tried to find something somewhere I could turn to get help. All addicts are one and the same, but nurses in particular face unique situations as a result of their work environment and have unique experiences apart from other addicts. Every time I Googled substance abuse in nurses, all I saw were things like disciplinary action or nurse fired, license suspended. There was nothing I could see where it said, you know, here's how we can help, or here's what we can do to help you. I also knew that if I disclosed what was going on to a counselor or went to employee assistance, that they were mandated to report my behavior. So there was no way I could get help without subjecting myself to disciplinary action. So I felt like I was in a catch-22 of sorts, and I did not know what to do. And I think that's something that I know that prevents nurses from seeking help. The number one, above and beyond that, though, is the shame and guilt that we feel for our behaviors, and not knowing as healthcare professionals that addiction is defined as a disease and an illness, but we see it, especially because of our profession, we see it as a moral failing. And we don't know where to turn. We don't know who to talk to. We're afraid. I was afraid that if I lost my job, I wouldn't be able to provide for my family. The financial consequences of that could have been horrendous. I was looking at losing my home. I was raising a child. I really was at the very, I had reached my own bottom. I didn't know what to do. And I think a lot of nurses feel that way. They're terrified, absolutely terrified of opening up and talking about this.
So this is the last question I have for you today, and it's a follow-up to the last. So if changes need to be made, or changes were to be made, what are some suggestions that you would give to your fellow colleagues, your fellow RN colleagues, to employers of nurses, and to us, the regulatory body? And you can answer them in whatever order you want, but what are some suggestions that you would have to make positive change?
I'm going to answer that. I'm going to direct those answers towards the three separate groups that you mentioned. So first of all, in terms of nursing colleagues, If you are working with a nurse that you suspect is abusing substances, I would say that the first thing you should do is report your suspicions to the nurse manager. Confrontation with the actual nurse in question will not likely work. Any confrontations directed towards me on the outside of my life, I'm not talking about in professional practice, were met with denial and hostility. So a face-to-face confrontation is with a nurse who is abusing substances is probably not going to work. In most cases in nursing, I always say to colleagues, if you're having a problem with a colleague, work it out with them before you go to the nurse manager. This is a unique situation where I would say go directly to the nurse manager, because the more she hears this, the more she's going to realize that there is indeed a problem and that this nurse is in trouble. Employers, specifically nurse managers, but anybody who's dealing with an employee who's abusing substances or who they suspect is, I think that they need professional support. Nurse managers are not equipped with the professional training to intervene with addicted nurses. Intervention is a profession, and there are people who are trained in that area. It's complicated, and I don't think it's fair to expect them to have to do something like this. It's something that needs to be done by a professional. Barring that, another nurse who is in recovery and has been through the same thing would be helpful in sitting down and talking to a nurse who's in trouble. But I don't think that it's appropriate to expect a nurse manager to handle this situation on her or his own without a directional professional support. And it ends up, unfortunately, that the only way the nurse manager is able to get these nurses into support or get them off the unit is by catching them red-handed. And to me, that's a last resort, and it's an awful thing for both parties involved. My nurse manager was extremely supportive. I actually was given a choice when I went to addiction and mental health services, and I ended up just telling them everything that was happening because I was so sick of lying. And I knew when I was doing that, I knew exactly what would happen. And the psychiatrist I was speaking to said, "You do realize that I'm going to have to report you?" And I said, "Absolutely." I said, "That's why I told you." He gave me the opportunity to report myself, which was a blessing in disguise. And I ended up calling my nurse manager and confessing everything. She was incredibly supportive. And one of the first things she said to me after I blurted it all out, and I can remember my heart was just pounding, and I didn't have the courage to go see her face to face, so it was a telephone call. And I'll never forget what she said to me after I told her everything. There was a pause on the phone, and she said, "Wow," she said, "that must have been very hard for you." And I was just astounded. She stood by my side while I went to the administrative body in the hospital to speak to them about what had happened, and then inevitably the disciplinary action process was commenced. So finally, my message to the regulatory body, which is the Nurses Association of New Brunswick, is that I have the union to protect me and my position as a nurse, and I understand that the regulatory body is to protect the patients, which is incredibly important. There's a need to support nurses in recovery because in supporting nurses who are in trouble with substances, we are in effect protecting our patients, because there are a lot of nurses out there struggling with substance abuse. And even if you believe, which I don't happen to, but if you believe that the substance abuse statistics are those the same as those in the community, that's a lot of nurses affecting a lot of patients. And I think that substance abuse has to be treated rather than eliciting a disciplinary response. I would like to see something called alternatives to discipline, which is a practice that's taking place in a lot of the states in the United States with good results, and that is where you can self-report to the Nurses Association or to the regulatory body and ask for help. Voluntarily give them your license. It's not a suspension. So you give up your license and you're required to go into treatment. There's no financial punishment. There's no suspension. It's not punitive. It's supportive. There are peer supporters who help you in reintegration back into the workplace when you're in recovery, when you've done all the recovery steps. So you're surrounded by support rather than feeling like you're being disciplined. And just reading about this and looking at the relapse rates and the success stories in recovery associated with this method, I think it's definitely the way to go to get nurses to seek help.
Thank you, Helen, for sharing with us today. There is still so much that we could talk about, but due to time, we're going to end today's session in a few moments. I just want to go over a couple of slides in closing, so just hang with us. The information that Helen has just shared and the information that NANB has researched and presented in the past has been updated and made into an e-learning module, as I mentioned earlier. And I would strongly encourage every RN and nurse practitioner to take a look at this module. If you are a manager educating your team on this important topic, talking about this and bringing this up should not invoke fear, but instead it should be seen as something that could save a life, as in a patient, but also in the staff or the colleague. You are helping your colleague with the goal of re-entering the workplace as a safe, competent, and ethical nurse. As the slide that I put up here shows, many researchers report that nurses are at a higher risk than the general population for problematic substance use because of the risk factors that you see there. And Helen mentioned many of them: fatigue, availability of drugs, the knowledge of drugs, and how self-medicating, as she shared with, self-medicating for that migraine is seen as acceptable. From the research, we know that the general population is increasing drug use, and we know that RNs are at a higher risk category for problematic substance use. So therefore, this is a topic that is still relevant for our profession to address, and that is why we are doing this webinar today. I want to end with the message. You'll see the picture of the iceberg to show that most likely what we are seeing in the official statistics at NANB, the 17 in 2009 or the 7 out of the 17, is most likely the tip of the iceberg called problematic substance use, because impairment severe enough to warrant action is very late in the illness quite often. Many people are able to mask their addiction, like Helen described, for years. So by educating others about problematic substance use, I believe there will be safer patients and healthier professionals providing clinical care. This is an important part, if you would just pay attention right here. If you have questions for Helen or for NANB, I encourage you to write us, to send us an email, because Helen and I are planning to co-create an article for our professional journal, Info Nursing, as a follow-up to this webinar. So if you have questions or if you have comments, you will see on the screen my email. It's Suzanne Priest at spriest@nanb.nb.ca. I thank you, Helen, and I thank you for tuning in today.